Better by the Numbers podcast. Presented by Life Metrics.
Another episode of the Better by the Numbers podcast, where we explore how doctors are using lab testing, clinical data, and precision medicine to improve patient care. I'm Aaron, your host. Today, I'm joined by Dr. Ruben Nazario, a physician executive in clinical informatics who specializes in how clinical and lab data move through healthcare systems, payer models, and reimbursement workflows, and why so much important patient information gets lost along the way. Dr. Nazario, thank you for being with us. It's great to have you here.
Thank you. Thank you for having me.
Of course. My first question is, tell me a little bit about your background and how you got to where you are today.
Sure. So my name is Ruben Nazario. Like I said, I am a medical director of informatics at Ability. Ability is a health data company that does interoperability. It connects payers, providers, across the various ecosystems in terms of data exchange. My work is right in the middle of the full data lifecycle. So, we sit in the intersection of where clinical data gets extracted, is captured, is normalized, is used downstream for, payers, for providers, or health plans, for various use cases like risk adjustment, like quality metrics, like population health management, prior authorization. And so in particular for laboratory data, the idea is how can you see data, laboratory data in particular, that goes from like where is order in the electronic health record through the laboratory systems, through the results, and what are the gaps that prevent that seamless communication that you think currently exists, how the seamless communication sometimes breaks down. Because of various data silos that exist in our very convoluted health system.
Perfect. Now, I know you focus more on like the macro sense of everything, but one of the questions we do like to ask one of our guests is every doctor has one test that stands out that shaped a decision in their life or a career path, or even a life. What was yours, and what made it so impactful?
Yeah, and I guess I should say I'm still a practicing physician. I work in both as a hospitalist in emergency departments and urgent care, and so I am, at the forefront or in the front lines, if you will, of all these data flows. In terms of like a particular test that I think that I've run that is particularly impactful, I think the biomarkers have been particularly important recently, but not necessarily in the clinical sense, although in the clinical sense, they're completely important. But I was thinking about it more as to what happens when that novel biomarker test doesn't get to where it needs to be. So for example, I may order a biomarker for, let's say, breast cancer or any other condition. I order it in my EMR, the result comes back, it's important, but by the time it reaches, for example, the health plan, it's some sort of like free text field or in what's called an unstructured data field that rendered that data unusable for those downstream systems. So, for example, a patient that needs to have a clinical gap filled because they have diabetes and they're not well controlled, or a patient who's waiting for the biomarker data for that came as part of a breast cancer screening and is waiting for that result, and treatment decisions come about from that result, and that result is not flowing through the system. Those are the gaps in the data exchange that really worry me, and that we are trying to solve in both in industry, but also the government and various regulations regarding data exchange.
Got it. Okay. You described yourself as sitting at the intersection of clinical data capture, normalization, and payer system. What would you say that means in practical terms?
Yeah. So, the health data system is very complex. There are many electronic health records, so there are the dominant players. There are many data silos. So if you think about in a hospital, the EMR that is in the clinical areas will send laboratory data or medication data to the pharmacy EMR. Maybe it's different. Maybe the radiology system is different. Maybe the laboratory system is different. And so, and then all that data needs to flow out of that silo, the hospital, to payers, to outside labs, to quality measurement companies, to health IT vendors, to the health information exchange in your state. And so that data, as it goes through each of those flows, may be broken down. Maybe it originated incorrectly. Maybe it's coded incorrectly. Maybe the data gets lost. Maybe it's coming through in, like I said, unstructured data fields. So in a PDF or even a fax that we still use to this day. And so that aspect of how to streamline all those processes implies that the data has to be structured in a way that all those systems understand it. So when I put that the patient has diabetes and the hemoglobin A1C is 7, that fact of the patient having diabetes and the hemoglobin A1C being 7 has to be standardized for all systems to understand it the same way. And unfortunately, we don't have that 100% interoperability, or what's called semantic interoperability across the system, because of the various data silos that may code things differently, transmit things differently, transmit data differently, transmit values differently, transmit results differently. And so those create those gaps in the overall picture of each of us, the overall picture of the patient.
Wow. So you're saying it gets convoluted along the way every time. So, so what is your perspective that most practicing clinicians don't usually see when it comes to that system? What do you see, and how, I guess, how can they be aware of it and better that system somehow, if possible?
Yeah. I mean, I think that one of the things that clinicians in particular, we don't worry about all these things. We assume that the back workflow of data exchange exists and it's exchanging information appropriately. But we also see at the front line how it breaks down. Every time you go to search for your patient's previous information, every time the patient tells you, oh yeah, I went to the urgent care and they prescribed me this, or I went to the specialist and they changed my dose of this, and that information is not there, or they went to the outpatient radiology center and they got, which is one of my pet peeves that happens when I'm in the ER, they go to an outpatient radiology center or the urgent care and they give them a disc, a CD of the images of that radiology study. And so in the ER, nowadays computers don't have CD-ROMs, so you have to kind of find a way, buy like an external CD-ROM, using like 20th century technology in the 21st century. Like I said, still using faxes, but to provide information about eligibility or like prior authorization. So the providers, the clinicians we don't question these things because we're just there to take care of the patient. We just have a limited amount of time. And so when I'm ordering a lab, I'm assuming that the lab is structured in the right way, that it's going in the right direction, that it's going to reach the laboratory, and the order is going to be carried out by the lab tech, and there's going to be the right patient and the right lab. And we take a lot of these things for granted. And when you look under the hood, you start seeing how a lot of these processes may be broken, may be incorrect. And we see it. We see it in clinical practice, but we don't think about what are the things, the regulations, the technologies that can help that. And so my role, since I live in both worlds, I live in the technology world and the clinical world, is in part to communicate to providers and to payers that there are gaps in the data exchange, and that those gaps could potentially be impactful for a patient. Like I said earlier, you could see a delay in a diagnosis or treatment that could potentially adversely affect the patient.
What's one way you can fine tune those gaps? Is there something that to get into the system to kind of uphold those gaps to where they happen less often?
Yeah, I mean, so as clinicians, one of the things that we can do is raise our voice. Every hospital has an IT or informatics department. Patient practices will have contacts with their respective EMR vendor, and they need to ask those questions. They need to ask the questions of why is the data not flowing appropriately? That's one aspect. for my perspective, is trying to establish and incentivize, health information technology companies, payers, hospital systems, EMRs, to follow the regulations that are in place for improving data exchange. So things like, regulations against information blocking, regulations about standardizing the data exchange and using the appropriate terminologies to identify clinical concepts. That those are the things that will eventually get us to a place where we have a true 100%, or nothing's gonna be 100%, but close to 100% semantic interoperability across the system.
Nice. Okay. And now I'm going to get back to a little bit of your practice and talk about some unique lab testing approaches, if you don't mind. So what is one, what is one way that you yourself use lab testing blood, genetics, gut, urinalysis with patients that might surprise other doctors?
Yeah. So, I work mostly in emergency department and urgent care. So most of the labs that I order are for, acute care typically. So I need a lab that within an hour or two is going to help me make decisions regarding the patient, whether the patient needs to be hospitalized, whether they need a procedure, whether they need any medication management, or if they can go home. We also, in the emergency room, in particular, we do labs that are related to chronic care management. And sometimes those happen because we know, for example, that the patient is going to be hospitalized or that the patient is going to follow with a primary care doctor. Sometimes there are send-out labs because, as you know, there are a lot of send-out labs that will take a couple of days, sometimes weeks. And a lot of times we'll order those labs and for the primary care doctor to follow up the results, because the patients come to the ER, they're gone, and they got to follow with the primary care doctor. And a lot of times the patient either may not know the specifics of the test or what it was for. They'll just go to the doctor and say, "Oh yeah, I was in the ER, and they drew a bunch of blood, and they sent me home to follow up with you." And so now that primary care doctor has to call the hospital, call the ER, or if they have interoperability with the hospital's the hospital's EMR, they can go and try to fish out where those labs are and what are the results and whether they need to be followed up or redrawn or have to talk to a specialist. And so that's the thing that sometimes, like, one of the things in the workflow between hospital-based and outpatient care that sometimes breaks down, because there are those gaps where the patient doesn't really know. They just know they drew some tests. ER, sometimes they'll have like a notification, especially if they're in the same EMR, between the hospital EMR and the community practice or the patient EMR. You'll have notifications of their labs, but a lot of times they're not, or the patient's traveling out of the area and they are in somewhere, they went to the ER, and there's no way to know unless they call the hospital and say, "Hey, can you fax me the results?" That still happens. And so trying to solve that problem, especially when not everybody's in the same electronic health record, is one of the things that, and one of those aspects that I hope that us clinicians can be cognizant about. And I know that we do. I know that we always talk to the patient, and they say, "Oh yeah, I got blood work," and I think to me it's not that fact. It's the fact of how easily accessible that data is. So that when you have the patient in front of you and they've gone to the hospital with labs, and they've gone to the outpatient radiology for labs, and they've gone to even the outpatient labs for labs, or then that data becomes much more easily accessible at the point of care from when you're talking to the patient. So you don't have to wait. There's no delays. You don't have to kind of call or fax or letters or any of those things, and make the workflow much more efficient.
Yeah, I could see that. Since you're talking about the patients and labs and different, can you walk us through a case with no patient names, of course, or anything, where the testing results made a real difference in the treatment or the outcome, or the pacing of when they got their resuls made a big difference?
Yeah. I mean, I can tell you several. One of the things that that is very impactful in terms of laboratory is drug levels. So, for example, patients that have epilepsy or particular seizure disorders, and when they come into the ER and they have a breakthrough seizure and you don't know why. And it's because they've changed the dose of the medication recently, or they've had an illness, or they fell on their head. And so this happens quite a bit, where then you have to some of the anti-seizure, anti-epileptics, you can check their levels in the bloodstream, and then you can say, okay, maybe you're not dosing, you don't have the right dose, and you're underdosing. Your levels are below the therapeutic range. Sometimes they're above, and you have to make those decisions. So I think that's one. It's like the combination of like chronic care and acute events that happens a lot, where drug levels in particular can be affected by a lot of different things. And then one of the areas that we're in the age of, in terms of genomics, is that ability of testing patients in their, for their genetic markers or their pharmacokinetics of the particular drug. And you can say, this particular drug works better for this particular condition that this particular patient has. And eventually it will be like, this is the type of dose that it would be. Those really complex interactions of medications and a person's, genomic makeup are certainly impactful. And we're seeing it, like I said, already in terms of like drug levels and genomic markers for particular conditions or cancers or immunomodulators. And that's the next stage in testing, is going to be that genomic information, where the patient's own, DNA evidence and genomic makeup will affect what are the testing and treatment decisions for that patient.
Yeah, that brings me to that was the next topic. It's so funny. So, like the new approaches and new technologies and lab testing that are coming out, what's making you most excited right now? There's like a layer now between the genetics report and a health plan. How are you mending those two worlds together?
Yeah, I mean, it's exciting about that. I mean, the scientific evidence for pharmacogenomics and other genomic testing and treatments is really encouraging. And like I said, we're in that era now where not only that, but things like CRISPR technology and gene manipulation is gonna open a lot of opportunities and potential cures for previously conditions that previously were thought to be incurable. There's CRISPR technology and gene editing technology that's helping in Huntington's chorea and in like sickle cell disease. And those are based also on the testing, genomic testing, other technologies that are gonna bring that to the fore and are bringing that to the fore. My concern in terms of like that's the rosy picture, everything's gonna be great view. I still see, because I'm a clinical data guy, so I still see where that disconnect can happen, where there's a lab report with a genomic profile that is sent somewhere, either to the payer or to the health provider, and not in a standardized format. So it could be like in a lab report that is in a PDF, or it comes this way in its clinical notes. And so even though the tests have become, extraordinarily sophisticated, there's that translation problem where there are these, incredible genomic insights sitting in reports that, payers or patient registries or care management platforms can read. Unless you apply technologies like, natural language processing and AI. And so that's where, the combination of the scientific advancement has to match the capabilities of the systems to exchange and to extract and exchange that data. Because otherwise it's just sitting in a lab report and someone's going to look at it at some point. But if you want to speed up the efficiency of and see the outcomes much more quicker, then you're going to have to speed up the exchange of that data.
Okay, and when it comes to those areas and those gaps, especially in testing, are you seeing something where some kind of workflow doesn't exist yet that could optimize this, like you said, like rather than it just sit there. Yeah. How would you, I guess, be at the forefront of making that more expedited and quicker?
Yeah, and there are organizations like HL7, for example, that uh, back up the conversion of these clinical concepts into structured concepts. There are other organizations like the MITRE Foundation, and obviously there are regulations that help frame the standardization of that data. One particular example, there's a standard called M-code. It's related to oncology clinical data. And so this is a standard where, people looked, organizations like MITRE and others were looking at cancer data and how it's not structured very well. You can look at a pathology report and see that a patient had, stage whatever, cancer of whatever body part, and that, someone reads that and there's a treatment plan that goes associated with that particular stage for that particular condition. But those data elements, that stage, grade, body part, a lot of times they were not structured in the right way so that you can exchange that data. Now that's becoming more commonplace that people adopt these standards, so that now when a pathologist writes down that the stage and the grade or Gleason score or whatever it is of the particular cancer, then there are structured data elements that say, okay, for this stage is this code, for this other stage is this code. And that way you facilitate that exchange of information as opposed to just being in some sort of, PDF lab report that got faxed somewhere.
Do you think that's becoming mainstream? That system do you see potential becoming mainstream, or is it already kind of getting some traction?
It is gaining traction, and it's but like anything, it needs work, and a lot of times these advancements lag behind a little bit until there are regulations that tell you need to do it. And that's part of what is happening now. There are a lot of regulations regarding information exchange, decreasing the information blocking between systems, particularly as it relates to recent legislation that's coming into the fore next year, where there are mandated standards for using the FHIR as the information vehicle between clinical data exchanges. And so, yeah, these are becoming much more mainstream, but there's still a lot of work to do, and there's still gaps in the information exchange. It's getting better. I think that people realize that you have to structure the data appropriately, and you have to make sure that the downstream systems are able to ingest that data. For example, laboratory data that comes from Quest or LabCorp or any specialized lab, once it leaves the system into the doctor's office or the hospital, there are, like I said, standards that say, this hemoglobin A1C or this, TSH, this is the code, and this is the code for the value or the result. That's becoming much more common. But there are still gaps, particularly in the translation between systems, because a lot of times you'll have a system that will code it to like a particular specificity or a particular terminology that is different from the accepting system, and then there has to be a translation layer in between to then say, this code that you're calling, the hemoglobin A1C, you're calling it this, and this is the result. This system is calling hemoglobin A1C this other code, and this is the result, and you have to have that middle ground, that almost that translation basically between the two systems, until we all agree that we're going to have the same code for the same things. But I don't think that's going to happen, because there's too much variability in the systems. There's too much variability in the coding, and frankly, there are incentives and disincentives to do that. Anytime there is, as you know, any inefficiencies are business opportunities, and so there's a lot of business opportunity because there's the inefficiencies in the system.
Nice. And for the other practitioners listening, what advice would you give them to not fall victim to those convoluted lab tests through those downstream systems, through those downstream labs?
Yeah, I think there's two things that clinicians, at the point of care in the front lines can do. Number one is try to structure your clinical encounter as much as possible. We're used to like dictating or handwriting or typing our notes. And a lot of times that note is still unstructured. You write down the family history, the social history, the presenting symptoms, the vitals. And so the more you can standardize that, the better for all those downstream uses. There are newer technologies like ambient AI that clinicians are using to facilitate the documentation of their clinical encounters, and those tools by themselves are starting to and already do start codifying the encounter automatically. So the clinician doesn't even have to think about it when they're dictating or where the ambient AI is capturing the clinical encounter and the conversation between the patient and the provider. They're already not only documenting the encounter, but extracting the clinical concepts that are significant for that encounter. And so that's going to be super important for those downstream uses. The second thing is when you're ordering a test, think about the data journey of that order, not just like, when I need a result, because that result is going to go through like the health plan and it's going to affect the quality measure, or it can just, affect a risk adjustment model or even a prior authorization request. And so the more precision you can capture in terms of that lab, you can start this is something that I started to do myself on clinical practice. When you're ordering a lab, a lot of times there will be a field for like the problem. What is the problem that you're ordering this lab for? It's usually not a required field, but I've gotten into the habit of like documenting what is the problem that I'm ordering that lab for because of that, because I'm thinking downstream when one of these engines that are looking at analytics or risk adjustment or prior authorization has that little piece of information, it helps streamline that process a lot better. And that way, for example, is a prior authorization request, and you're ordering a lab and you put the diagnosis that you're thinking of, that saves you like 1, 2, 3 phone calls or faxes or calls to your medical staff, from the health plan asking, hey, why is it that you want this lab? If you already included the diagnosis, then there are algorithms in those prior authorization tools that then will say, okay, fine, I see this lab and I see this diagnosis, I'm just going to authorize it. And so the better we can be precise about why are we ordering things, and the better it is for those outcomes. And then we can get those processes much more efficient, and that will help us better in terms of patient management.
Yeah, just something as simple as being very specific about what's going on with the patient.
Yeah. We don't think about those things. I'm just ordering a test and I just want the result. We just have to kind of think a little bit more tactically about, I'm ordering this lab and I want the result. What are the things that I can do to connect the dots, so then we can, have those results quicker.
Now, and if you could leave our listeners with one key takeaway about testing and patient care, what would that be?
Well, I mean, not only I've worked in data, but I also work in clinical decision support. There are a lot of more tests now than when I first started practicing, 25 years ago. And so the number of tests for particular things also has exponentially increased. And so we need to be a little bit more cognizant, not only about those, but about using resources that are available to us to say, if I want to diagnose this patient with, type 1 diabetes or type 2 diabetes, or if I want to, or if I want to check the biomarkers, there are decision support tools out there. There are clinical databases that can help you get that information. But you can also use, the AI models are increasingly getting into this space of, you can, put a whole clinical picture of a patient, you have to be careful about HIPAA, of course. But putting clinical information and getting recommendations about diagnosis, about testing, about treatment, And so we have to embrace the technology, but at the same time, be mindful that technologies are not 100% perfect. There are hallucinations in some AI systems. They may confuse things. And so obviously we're trained in clinical evidence and evidence-based care, and we have our own experiences, and we have to have that nice combination of being technology savvy and marrying that with evidence-based care, marrying that with our own experience. And that combination of things was going to serve our patients in the best way possible.
Perfect. Well, thank you so much for sharing your insights today, Dr. Nazario. I appreciate it.
Thank you.
For our listeners who want to learn more about your work and what you do, where can they find you?
I'm in LinkedIn, and I also have a Substack called the Clinical Data Gap.
In the link for sure. Well, thank you guys for tuning in for another Better by the Numbers podcast. If you enjoyed today's episode, share it with a colleague or friend or anyone who's just curious about the future of medicine. And don't forget to subscribe. It's for more insights from doctors who are pushing care forward.
If you are interested in genetic testing, blood work panels, or other resources for your practice or business, check out lifemetrics.com.